Recording
This
in
meeting
progress.
is being recorded.
Good afternoon, everyone. Thank you for joining us for our first summer speaker event. Our topic today is federal and state health policy making priorities now. I'm delighted to introduce Audrey Smith, who is a senior Audrey, apologies, a senior staffer for Senator Joe Manchin, and Hemi Tewarson, who is the Executive Director for the National Academy of State Health Policy. Welcome to both of you, and thank you for joining us. Audrey Smith, I should say, is also, of course, a graduate from George Mason, and I'm always delighted to have Audrey here. Audrey, I wonder if we could, and I should tell our audience, please, we will have presentations from our two speakers, an overview of federal and state policymaking priorities, and then we invite you to join our Q&A using the Q&A function, add your questions, and we'll get feedback from these experts in health policy. Audrey, I wonder if we could start with you, please. Can you give us an overview? What are some of the hot topics being discussed now? I'm going to guess likely in the context of the appropriations bill for 2023, but that and other priorities.
Yeah, thank you, Allison, and thank you for having me here today. I'm just going to start off so we can have a nice open discussion here today, just sharing that all views are my own and are not to be attributed to the senator. Just looking forward to speaking with you all today. So view from Capitol Hill, as we all are aware, we are still in the ongoing COVID-19 pandemic. And a couple of things that are on the docket that Congress has to deal with this year includes the fiscal year 23 appropriations, which includes the Labor, Health and Human Services appropriations and the FDA appropriations to provide all of our discretionary spending for next year. The previous year, fiscal year 22 appropriations, we didn't actually pass that bill until March of this year. So hoping to get that a little bit more timely going into next year. It is also the year for user fees. If you don't know what those are, manufacturers, drug manufacturers in particular, pay a user fee to the FDA for them to review their applications. And we have agreements that are passed every several years between the drug makers and the FDA to determine what those user fees can be used for. And it is a major funding component of the FDA. As you may be aware, headline news, FDA is under a lot of pressure right now from the infant formula crisis. And so addressing that and some of the issues within the FDA is also a top priority. You'll continue to see investigative hearings on Capitol Hill. Some other top issues include mental health. We have both the House and the Senate working on mental health packages. The drug epidemic has gotten significantly worse during the COVID-19 pandemic. Mental health, especially youth mental health, has also deteriorated. We saw a report from the Surgeon General saying that youth mental health is at an all-time low. So Congress is looking at how to deal with that. We, of course, are also still discussing drug pricing. Oftentimes you're hearing about that in relation to reconciliation. So that's still being discussed, particularly on the news. And the public health emergency. We are still under the public health emergency. At some point that is going to end. And when that ends, a lot of the waivers and flexibilities that we've had and we've enjoyed over the last several years will be coming to an end. So the buzzword that you're going to be thinking and hearing is the public health emergency unwinding. So a number of people losing their Medicaid eligibility. And so we're thinking about that and how do you transition that or smooth that. Also ACA premiums. We've been enjoying enhanced ACA premiums. In August, insurers will be setting their rates for the next year. And so unless those are addressed, we're going to potentially see our premiums on the ACA marketplace increase. And so Congress has a lot on its plate. And geopolitical and domestic issues keep coming up, and the to-do list keeps getting longer and longer, and the days of work keep getting shorter. So just a few things.
Excellent. Thank you so much for that overview. And we'll have lots of questions for you about that. Hemi, can you give us an overview of what states are thinking about right now and working on?
Yeah,
and we have some slides that we can present here for you also.
And, you know, if we want to stay in a conversational format, we don't need to use the slides. So I'm happy to just answer the questions. So whatever works for you.
I think your slides might be helpful. We'll go ahead. Mm-hmm.
Okay, great. Well, first of all, thank you for having me. It's great to be here. And I think I did this last year too. So great to be back. So just to give you a little overview of, I really appreciated Audrey's overview, because obviously what's happening at the federal level does migrate down to the state level in a different way and with different priorities that states have to address. Just to give you some context about my remarks and where I'm coming from. So I'm the executive director here at the National Academy for State Health Policy, and you may not be familiar with NASHP. NASHP we're a nonprofit, nonpartisan organization that works really closely with state leaders, really trying to help them advance state policy ideas and solutions. And I would just say one thing that's really, I think, unique about NASHP is we work with all different types of state leaders. And that's important because they all bring different perspectives. So we work with state legislators, we work closely with governors' advisors, we work with state Medicaid directors, we work with public health officials, we work with social services agency staff. And so each one of them, much like at the federal level, they're tasked with sort of their piece of the pie. And in healthcare, it's all related, but sometimes it isn't always done together. So wanted to just share that for the perspective of what I'm going to bring today. So we can go to the next slide. So one of the things I just wanted to say in terms of, you know, what are we thinking about on the state level? 2022 is an interesting year. It is a year at the state level where we're going to have 36 gubernatorial elections. That is no small number. There are 8 states that will absolutely have a new leader, and they're listed here. But there's also some really tight races across the country. I think the pandemic and other sort of things happening have led to very fierce political battles, I'll just put it that way, in different states. And so you'll probably see more new governors coming into office when we are entering into 2023. All that to say, what that means is when states are thinking about health policy and they have a governor who's running again, an incumbent, and there's a number of them, you can see the shift. You can see the shift of what they're trying to do and what they also have to do during their campaign. And it affects how quickly state policy moves and what the emphasis will be. And there are certain topics like prescription drug pricing. How are we going to effectively deal with the end of the public health emergency? How are we going to make sure we have a strong economy, healthcare workforce? Mental health is another topic. These are all things that are floating to the top, not just in the context of, you know, an election cycle, but even more so when you have folks sort of running for office. The other thing I always like to point out too, unlike our federal Congress at the state level, we are now ending the first sort of 2022 legislative session across states. Their sessions are much shorter. Some state legislative sessions are 2 months, 3 months, 4 months. Many majority end by May, June. So we are really seeing a slowdown in terms of what state legislation passes for this year, and really our eyes turn towards what's going to happen in 2023. And that work starts in the fall for, you know, figuring out, okay, what is going to actually be enacted with this at the state level. Okay, next slide, please. So just in terms of the big topics, and Allison, I'm happy to just talk at high level right now, and then we can get into sort of more details in the conversation.
Excellent.
So I think these topics don't look all that different from what Audrey talked about in terms of what they're focused on at the federal level, but I'll just say a couple of things. Healthcare workforce, that's always been a challenge across the states. I will say it's much more of a crisis now than it has been in previous years. And I use that word with purpose. So, you know, we look at the state of the states every year. What are governors talking about? What are they focusing on? It's always economy, it's always education. And then there's sort of your typical healthcare, you know, opioid epidemic, et cetera. Healthcare workforce has come to the top. It was in over 25, I think, gubernatorial state of the states this year. And that is unusual. And I've been following this for a number of years, back to my days when I was at the National Governors Association. And that's because we have a combination of factors happening. We have the pandemic where, you know, staff like nurses and doctors decided we're going to retire. We're going to retire early. We're going to retire for a number of reasons. We have we had surges that needed to be filled. And so there was real pressure on the system to actually get the staff. And then we have things popping up that Audrey talked about on the behavioral health side, really a mental health crisis where there's not enough providers to really meet the need. And I'll just mention the long-term care side. The pandemic was a real pressure point for nursing homes and helping older and disabled folks stay in their communities. And we have a shortage of workforce there too. So there's a couple of pieces to this that it really is adding to the picture of why it's coming to the top with a challenge. On the public health side, so I think there's a lot of discussion at the state level about how do we improve our public health system? What comes next? We have been through this really difficult time period. Who should have the authority? Who should be able to say when a state closes? Who should be able to decide what steps a state needs to take in a public health emergency? And so you're seeing a lot of activity in different directions, frankly, across the states. You're seeing some state health departments getting sort of moved to the Department of Human Services. So you have mega agencies. You have some states doubling down with all the federal dollars coming to them to invest in public health and figure out how to sort of make it stronger. So I really think we're going to have sort of a lot of differences across the country, depending on how a state orients itself to what comes next. I think Audrey mentioned the end of the public health emergency. So that I tie into, like, when is it going to be? I think all the states thought it was going to be in July. It's not going to be in July. We know it's going to be at least in October, and most likely move to January after the elections at the federal level. So, I think the states are hoping that we don't have to sort of address this until January, 2023. But when that happens, that's going to be probably the largest eligibility event we've had in years. There will be millions and millions of people who will no longer be eligible for Medicaid. The estimates range from 5 million up to 25 million across the country who will no longer be eligible, depending on, different factors. And so, the ability to process those, the ability to make sure that folks who are still eligible stay on the rolls and actually sign up again. They've been on for 2 years and haven't had to take any action in, at a high level. There's been some exceptions, but they haven't been redetermined. So there's going to be a lot of education, explaining, thinking about where do they move to if they lose their coverage. And so I can talk a little bit more about that in detail, because that is a huge looming challenge for states. And just on the other two, the cost and value of healthcare, prescription drugs has been on the radar for a long time for states. And I will just say, we here at NASHB do a lot of work on prescription drug costs and health system costs, helping states figure out where to go next. I will say I feel like the states are leading the way, frankly. The biggest levers are at the federal level, but the federal level has been much slower. It's more difficult to get that type of legislation through. At the state level, there's hundreds of bills that have been going through over the past many years. Interested, we track the prescription drug bills on our website at NASHB, so you can always go to get more there. And Allison, we can talk in more detail about what are the themes, if that's of interest at the prescription drug side, as well as on how do we address health system costs, because that's also a big theme that we're working on here. And last but not least, the social determinants of health and equity. So, there has been, the past many years, states are really thinking about, we know our health is linked to our housing, our food, our transportation, all of the different pieces that sort of make up a total person. And so I think states have been thinking about, what do we do? How do we invest in this? Medicaid can't pay for everything, but can Medicaid do more? And what are the other supports we need to build in? And as with the federal level, these systems are siloed, right? They get different funding sources, they have different agencies sometimes. So it's really a lot of effort to bring it together. I'll say what's coming to the top on SDOH right now for states is housing. And with inflation, combined with what's happened with the pandemic, states are really thinking about where can we go next with housing, because it has been such a challenge for so many folks, as well as food insecurity. And then last but certainly not least, equity. So I think states are addressing equity in different ways. I will just be very honest. The more blue states are really taking on how, equity is a public health crisis. How do we address that? Whereas other states are reticent to really ask about, they're thinking about it as health disparities, and how do we have sort of a robust workforce where everybody has an equal, ability to be employed and do, the things that we all need to do to have sort of fulfilling lives. So maybe Alison, I'll stop there and we can dive into any of those pieces.
Excellent. Thank you both for the overview. And these really are huge and difficult topics. I wonder if we could start, Audrey, with, of course, the looming changes in coverage, let's say. And I realize we don't know what the appropriations for 2023 will look like, but thinking back to the 2022 appropriations and where the different views are on the premium subsidies, what can you say might be the federal impact on coverage? What vehicle will be used? Is it the Appropriations Act? And where do you see sort of the different opinions on the premium subsidies?
So the premium subsidies, the enhanced premium subsidies for those kind of changes, increases eligibility for who's eligible for ACA premium subsidies, the premium tax credit on the marketplace, and increases the amount that they would receive. And I think there's been recent reports that came out saying that it increased overall number of people enrolling in the marketplace. We had an all-time high of patients actually being insured. For the enhanced premium subsidies to be continued, it's at a pretty high cost for a 10-year window. It's something around $200 billion over 10 years. And to be able to pay for that and to be able to pass that, it would need to go through some sort of reconciliation process. That is the buzzword of the last several years. So the reconciliation bill needs a simple majority in the Senate. And in today's day and age, that's 50 senators. And they've been working on reconciliation for quite a long time now. And the trick with reconciliation is ensuring that every component is paid for. What are the pay-fors that 50 senators can agree to, and what can we fund with those pay-fors? I think to get enhanced ACA premiums continued beyond the current level, beyond the current timeframe, is going to have to go through some sort of reconciliation process, and it would have to be properly partnered with pay-fors. Now, we don't have any sort of draft or anything right now. That's kind of what's being discussed. There's a lot of priorities in this space. I mean, Hemi hit on quite a few on nursing homes and healthcare coverage and healthcare workforce and housing, obviously. So it's kind of figuring out what are the various puzzle pieces that can fit together. I think the timeline is really short. As Hemi touched on, we have an election this fall. And that could very well change the makeup of Congress. We have a very slim majority, Democratic majority in the House and the Senate. And depending how the midterms go this fall, that could drastically change, and that would drastically change the administration's ability to meet some of their priorities. So I think ACA premiums would have to go through a reconciliation process rather than appropriations. But I know appropriations is definitely looking at healthcare workforce.
Excellent. That's extremely helpful. Thank you. And when we look at the Biden budget, just one more question, if you don't mind to follow up, Audrey. For 2023, there's a component that they speak to about the deficit neutral reserve fund. Can you just explain that to our audience so they can track the news a little more fully?
I can try. So a deficit neutral reserve fund, I mean, essentially, it's a lot of this is tricky accounting. So it's how we are utilizing funds that are money that may have been spent, money that we saved, and then we reserve the money to be able to use for a different purpose. For a deficit neutral is a program that basically will not increase costs because maybe it can pay for its own costs or it balances out. So it's honestly, when you hear deficit neutral reserve fund, there's a second one that is escaping me. It's predominantly tricky accounting and budgeting of how federal government looks at our funding. We do a lot of 10-year projections. We rely on Congressional Budget Office, a lot of economics. One of the funny things in healthcare that we do as well is, generally speaking, if you keep a patient healthy, you have them going to their primary care, taking their medications. They're less likely to go to the emergency room, which is a big expense, so they'll be cheaper in the long run. However, when you're doing accounting and the healthcare side, you have to account for the cost of the primary care visits, the drug pricing, the cost of the drugs, and a potential ER visit. So if you're adding on some of these, what should be savings in the long term for healthcare, it's actually still going to cost you money when you're doing the accounting for it. And so if you're able to write off some of those potential costs into a separate account, you can pay for itself. So it's a lot of this is just tricky math.
Excellent. Thank you for that. And any sense of whether this would be, and any of these major priorities that you outlined might be a before election or after election agreement? Any sense on which topics might fall one side or the other of that dateline? Or
that's honestly the question. Obviously, I think the administration wants to get something done before the election. As I mentioned, there's also some fairly tricky timelines regarding insurance needing to set their rates for next year. So there's repercussions for timeline. But it's trying to put together something that can garner the very slim majority that we have and do the accounting that everybody agrees to. There's a lot of math that we do. So my George Mason's economics classes come roaring through.
Excellent, excellent. So Hemi, of the priorities you outlined, and there were a number of them, which are the ones where you need the most federal relief, the way you're really running into a federal legislative challenge for the kinds of initiatives that your states are trying to implement?
Yeah, no, thanks for the question. So one thing I did want to focus on is the end of the public health emergency and what you all were just talking about with respect to the enhanced subsidies for the marketplace. So in full disclosure, NASHB, we are the pseudo association for the state-based marketplaces, and that is essentially the 20 plus states who've decided to have more control over their marketplace, and they brought different functions in-house. Which means that they are sort of more state operated than the federal marketplace that operates in other states. And we've been having a lot of conversations with those folks along with the Medicaid officials. And there's a really big concern that when we get to this cliff, essentially at the end of the public health emergency, and states will have a certain amount of time to redetermine Medicaid folks, but really it's, up to 14 months, and some states are going to take as little as 90 days. There really needs to be a clear pathway to other coverage for those who are no longer eligible. And really one of the key factors in that is going to be the marketplace. And I think the concern is that right now we have, there's lower premiums, people are signing up for the marketplace, they feel like they can access the coverage. If those are right now scheduled to end at the end of this year, if Congress does not extend those subsidies, we are going to lose a lot of people on the coverage rolls because folks will determine that it is too expensive to go to the marketplace from Medicaid. Right now, states feel like there's a seamless path where they could, make sure people are educated. Not everybody will go, but there'll really be a lot of opportunity. Without that, there will be lots of folks that we lose and who will be uninsured. So I think that's a huge ask for Congress, and not to put Audrey on the spot, but just more generally across the Senate, really thinking about, if there's prescription drug reform, which is another priority I think states are very interested in, although they're doing their own thing. A lot of the reforms are on the Medicare side, so less tangible for states. But assuming there's some levers pulled there, that generates a lot of savings. Which would give an opportunity for things like the enhanced subsidies to actually be enacted. So that would be, I think, an ask. I think the other ask is on healthcare workforce. I really do think states, and the feds can only do so much, scope of practice laws, which allows, folks like nurse practitioners to practice independently without the supervision of a doctor. That really is at the state level, those licensing decisions. I've done that work for years. It is tough stuff. Practicing physicians don't want to give up that supervision. They don't think nurse practitioners should operate independently, for just as one example. Same thing with dental hygienists. But I think, those of us who've been in this field for a long time, we really think the time is here to think about how do we really view our healthcare system? What is the right staffing model? And some of that is going to be federal investments in recruitment, getting more opportunities for training and education. Right now, there's, I guess, so anecdotally, we've heard more nursing applications than there are slots. So, and I really do think that's a federal lever that could be pulled in terms of how do we open up those opportunities. But I also think we need to be thinking as a system, where do we go? How do we think about rural areas? What are the staffing models? States have to play a huge role in that, but I think the federal government can have some clear impact. And the third piece I would say is continued investment in public health and behavioral health. I think there's a lot of debate going on right now about, do we continue to spend money for public health? I don't think there's been a lot of money spent, and states have to spend more of stuff that's already been appropriated. But looking to the future, what is the plan? There are these cliffs now that states are going to face after the 2 years of funding that they currently have. So does all of, and they're like, well, that means we can only invest in something that lasts 2 years. That doesn't help thinking about long-term sustainability. And that's true, I think, on the behavioral health side too. So those are a couple things I would raise. Plenty for Audrey to work on with her comments.
Excellent. And not to put the pressure on Audrey at all. So a couple, drug pricing has come up now a couple times. Both of you have mentioned it. Audrey, what are the legislative vehicles that are likely to lead to a change in our approach to drug pricing, if any? So what is the piece of news to watch on that?
That's back to reconciliation. One of the most popular provisions within drug pricing is letting Medicare negotiate. So what does that mean? It allows the Secretary of HHS to negotiate with drug companies on what Medicare will pay for the drug. That would also mean that the price would go down for seniors, and they're targeting some of the most high-cost drugs on the market that have no competitors. How we currently deal with lowering drug prices is competition. You need generics to come onto the market to lower the cost, and in lieu of that, you just have incredibly high costs. And so allowing Medicare itself to bring down those costs. Medicare negotiation has no Republican support. So the only way you can get it through the Senate is through reconciliation. The Senate has a filibuster rule where to get a drug pricing not through reconciliation through, you would need 60 votes. That's 10 Republican senators to support that. In 2019, the Senate Finance Committee put together a bipartisan drug pricing proposal. It did not have negotiation in it, but it had a number of proposals and ideas in there to try to move the ball forward on drug pricing. But it didn't go anywhere. It never saw the Senate floor for consideration, and it just didn't have the votes. So really the only way to get something like that done is through reconciliation. Now, the tricky thing with reconciliation is it's like legislating with a straitjacket. We can only make changes to items that have a federal budget impact. So if you want to say cap the price of insulin, we can only do it for Medicare programs. We can't do it for commercial markets or insurance under ERISA. We can only do it for federal insurance programs, which makes it really tough and brings up a lot of fights on really archaic rules. Although I will say the Byrd rule is near and dear to our hearts since it's named after the great late Senator of West Virginia. It's reconciliation is where you're looking for the ACA premiums and where you're looking for the drug pricing. You might be able to get a couple things via the FDA through the user fee bills. The other big one is, as Hemi said, states. States are doing a lot. West Virginia actually just passed one of the most aggressive PBM regulatory bills. And so it'll be very interesting to see if they're able to actually implement that without too many legal challenges.
So the PBM being the pharmacy benefit management. So the sense is that the federal provisions are standing in the way of some of the state initiatives, is what I'm hearing you say. But clearly Medicare and many of the Medicaid provisions are going to have to come through federal legislation. You mentioned the past where so we have a political divide in terms of price negotiation for Medicare. What are some of the other debates that came up at the time of possible policy solutions around drug pricing?
So the main three that are being reviewed is Medicare drug negotiation, Medicare Part B inflation rebates. So essentially, if the cost of the drug rises faster than inflation, the drug company is required to pay Medicare rebate for that. And the third one is called Medicare Part D Redesign. So basically setting a cap on the out-of-pocket caps that seniors pay per month. Part D is the drug benefit in Medicare. Putting a cap on what seniors pay per year, kind of rejiggering the liability of the insurance plan itself, and putting a cap on insulin under those programs, as well as smoothing the cost. So if you have to pay a high drug cost in February, that bill is not due in February. You can smooth it over the course of the year. So trying to make Part D more affordable for seniors. And so those three are kind of the big three that's been in the reconciliation drug negotiation discussion. As I mentioned, there's also been a little bit on PBMs requiring some transparency on where the rebates go, but a lot of the PBM proposals don't have a federal budget impact and so have a hard time getting into a reconciliation package. So we kind of have to rejigger some of that. And those are some of that's the main big ones that we're looking at through reconciliation.
Excellent. And Hemi, what do you see as some of the, we just heard about the West Virginia innovation. What are some of the things that you see states trying to do on drug pricing on their own?
Yeah. So they've been very active for the past number of years, actually, on drug pricing. I'll say a couple of things. The insulin caps, the states are implementing them. There's a number of states that have decided to cap the copay for insulin on their own across payers in their state. I will say one of the challenges with that is it helps the consumer at the counter, but it doesn't slow down the sort of drug costs sort of beyond that. So one purchase. So that's a challenge with that, but I think it's people feel like they needed it, and so they're taking action. A couple of others, PBM, prescription benefit manager reform, definitely the most popular. I think we have 127 bills that we saw, actually being debated across states this legislative session. It's a lot about figuring out more transparency, understanding where is the money going. I think that's the biggest challenge when you think about where to actually push on reform. And one of the things is focusing on how do we actually make sure some of those rebates are passed on to consumers. So that's part of what West Virginia is trying to do amongst many other states. There's a really interesting conversation going on around international drug prices. And this was actually from the Trump administration. They were very interested in thinking about, Canada pays a lot less. They're our neighbor. Why is that? How can we think about doing things differently in the US? And so coming from that, there's a handful of states, 6 now, but probably more, that have already passed legislation on importation. And, in order to actually move forward in importation, they have to get approval by the FDA. No state has gotten that approval yet, although the last administration opened the door and the current administration says we're still talking. So I think, personally, I think there's some challenges with that with respect to actually getting the drugs from Canada. Canada is the only approved country for that. So, whether Canada is going to be willing to send the drugs over, will they have the processes in place to be able to do that? I think that's still unclear, and there's no federal approval yet on that front, but states are still talking about it. I think what's emerging that actually NASHB is working on is international reference pricing. So that's really thinking about, as we think about what prescription drugs should cost, do we have a benchmark from other countries to start the conversation? And there's a couple of states across the country that have established what's called pharmacy PDABs, prescription drug affordability boards that are really sort of setting the conversation around here's for a handful of drugs, here's what the cost should be based on a lot of different factors. Maryland, Colorado, Washington State's the most recent, Maine, New Hampshire. So I really feel like that's emerging for some states of we need to have some sort of advisory board. They would love for the feds to do it. I don't think they hold that hope that we're going to have that at the federal level. So they're taking action themselves. And the last one I would just mention is transparency. I think there is a lot of interest at the state level on understanding, passing legislation on manufacturers. Can you report on, what your drugs cost? Pharmacy benefit managers, can you report? 340B entities, not to get into that whole conversation, but I think there's a lot of interest in just having an understanding so there can have a more robust conversation to figure out what to do next.
Right, and we have an interesting audience question, which is on how do the state and federal levels collaborate on a topic like drug pricing?
So I will just provide my thoughts, and then Audrey should provide hers from the federal level. So I think at the state level, there's a little frustration that the federal, both on the executive branch as well as the legislative branch, haven't really been able to move much policy on prescription drugs. I think in terms of collaboration, there are some levers that states don't have, like the patents, the bringing more generics to the market. States can't control that. That's really sort of in the federal purview. So I think, state leaders know those could make huge changes in the market, but there just hasn't been the political appetite to move some of that forward. So, but then
there's an awareness, right, of where the boundaries are in terms of what policies each level can push forward. And is there a sense that there's a cooperation on designing demonstrations, or does that typically not happen in the drug policy space, but perhaps more, and we'll get to this topic, behavioral health, for example?
I think there could be. Importation's an example, right? If the federal government has to approve a state's ability to import drugs, that is sort of a sort of model for potential collaboration. It hasn't happened yet. I think there's a lot to work through, but I think there's a couple of examples. I also think on the transparency piece, and we've been talking to sort of the federal government about this. The federal government could collect data and share it with all the states, so states don't have to do it individually. We have 50 states. That's a lot of different people doing different things. If there was sort of a federal lever pulled where there was more reporting up to a national level, and then states could benefit from that, I think that could be a great model too for collaboration.
And then Audrey, from your standpoint, what are some of the models, or how does the information from states' initiatives arrive at the federal level? Through what mechanisms, and how does it take it into consideration? And obviously, as you said a number of times now, you're constrained by the number of votes you have and the kinds of things that you can address. But kind of walk us through what that looks like.
Yeah, so Hemi actually said this really well. One of the best things to try and try out a new policy is either through a state policy or through a demonstration program. Because when you talk about drug pricing policy in general, one of the things that you have to think about is the complicated network that makes up our drug pricing, from the manufacturer all the way down to the patient, including insurers and pharmacists and pharmacy benefit managers, and how the money flows and how that network interacts. And if you press one lever of the drug pricing policy, how costs are going to shift, what it means for downstream, how it impacts how the different players in this field will react. And that's one of the things that we run into when trying to discuss drug pricing, because if you mention one proposal, everyone will bring up how this is going to shift costs, what some of the unintended consequences of the proposal could be, and what that means in the long term. So when you do that on a federal level, it's like trying to turn a barge, because every time you try to make a proposal, you get all of these other theories that come into play on what that would mean. When you try it out on a smaller scale, you're able to see a little bit more of that cost shifting in real time and see what that impact means, and then be able to extrapolate that data to a federal level. Now, we still keep running into these discussions on if you do one thing, what that means for long term. Hemi also mentioned if you just put a cap on the cost of insulin, while that would help the patient, because that'll immediately reduce what they pay at the pharmacy counter, that cost still has to go somewhere. The cost of that drug isn't magically $35. That cost of that drug, the money is spread out through Medicaid programs, through Medicare programs. And the more that we expense its insurance, the less money there is on other programs, such as if you want to increase what Medicaid pays to behavioral health providers. So we have more behavioral health providers. You don't have as much money there because Medicaid has to pay more for the cost of insulin. And in Medicare, the Medicare Part A trust fund is supposed to go insolvent by 2026. When that happens, you're potentially going to see benefits reduced to patients and payments reduced to providers. And we're already talking about a provider shortage. West Virginia is a very rural state with majority Medicare patients, Medicare and Medicaid. And our providers are already struggling to subsist off of those insurance programs alone. And so if you reduce those benefits even further, you're going to see less and less providers. Which becomes a really serious problem.
Yep. I should say that as a academic institution, we're deeply interested, of course, in topics of workforce, and we'll have an entire separate panel on workforce issues. So if you're surprised by the fact that I'm not deeply engaging on workforce at state and federal levels, we're actually devoting an entire panel to that topic. And we will also have one on the opioid crisis, but I still can't resist the temptation to say, what do you see as at the federal level, the behavioral health priority issues? Is there a disagreement or are there some solutions? Much in the way you talked about drug pricing, is there a sort of a set of go-tos and just lively discussions at the federal level? And then we definitely want to hear about state.
So mental health is actually a great topic. So the Senate Finance Committee, Senate Health Committee, and the House have all been working in bipartisan working groups to develop mental health proposals. So Congress actually kind of working is very exciting. In mental health, we do a lot through appropriations. We have a lot of grants and block grants that we send to states to utilize. Now, it's great because it's a lot of funding directly for behavioral health and mental health going to states. It's difficult because grants are finite and they also are not consistent, reliable funding, because your grant might be for 5 years. And even though you've been receiving that grant every 5 years for the last 15 years, there's no guarantees that you'll get another 5-year grant. So that creates a lot of lack of sustainability in this market, which makes it hard to build it out. So I think in mental health, there's been a big push towards more graduate medical education slots, training more providers, expanding Medicaid coverage and Medicare coverage. So you have a lot more of those sustainable funding sources for these programs, as well as certain demonstration projects to try things out, some more flexibilities, expanding eligible practitioners. Telehealth is a big one, and expanding that. So I think the various committees are looking at these bipartisan proposals. In the end, it's reducing certain restrictions while trying to maintain quality and providing funding. And I think with the crisis that we're seeing on multiple fronts, there's a lot of interest in doing this.
Excellent. And Hemi, what do you see happening at the state level? And both of you also address mental health, and in particular, mental health of young people. Do you see differences in the states and the kinds of things they're proposing to do by age group, for example?
Yeah, and I think, we have been spending a lot of time on this with state leaders. And I think the first thing they'll say is none of these are new problems. We have been working on this for a number of years, but we have a moment. We have a moment where we have to decide what are we going to actually move forward on policy because of the great need that we are seeing that's just different, especially on the children's side. So a couple things. How do we address mental health in schools? I think that's a topic that's coming up a lot. What role does Medicaid play? What other supports can schools get directly? We don't have enough school counselors. The training is not there. And so some of the sort of discussions going on at the federal level of, investing in those pieces, I think will be very helpful. But states themselves are thinking about how do we think about funding differently and what do we do in terms of investments? I think integration of behavioral health and physical health has been a topic of conversation for a while, and a lot of work going on at the Medicaid level of how do we bring those worlds together? How do we have sort of more seamless coverage? Can there be lower levels of mental health, behavioral health needs addressed in primary care offices? How do we support those doctors to help really address some of the needs of the patients? Because we don't have enough child psychologists and psychiatrists right now. There just aren't. So what are the other things we can look at? On the SUD side, I just did want to mention peer supports. So really thinking about how to grow that peer network of folks that have lived experience that can help folks get through these sort of difficult challenges while they're in treatment, I think is another piece. And one thing I'll just say, just taking a step back of like, where do we go on all this? I think we have to also think about the private sector, the commercial sector. There's parity, but mental health parity has not been achieved. And my personal belief is this can't all be done through Medicare and Medicaid. We have to build up networks and have sort of the commercial folks, and the employers are focused on this now because there's all this new need for mental health services. How do we get them more involved? How do we think about true parity? And, you know, some of the state leaders are like, can Congress think about something like a surprise billing with mental health parity? You know, what are the new ideas that we can bring to the table that's going to really shake up the system a little bit, so we have more to work with?
Terrific. Thank you. And we had a couple questions that are going to tie them together because I feel like they're related. And what has to do, Hemi, if you would address Medicaid, we do have the at some point, the end of the public health emergency, thinking about Medicaid and inequities. What are states prepared? What are they thinking about in terms of equity and Medicaid as it relates to the end of the public health emergency?
Yeah, I think there's a lot of concern about who's going to be left behind when we have to do these redeterminations, and it really does include, you know, rural populations, you know, people of color, et cetera. So a couple things that states are working on, and they do have plans, but you know, no plan is perfect and can always be amended. I'll just say that. One is about prioritizing populations. So who do we think is most at risk? And what they've, you know, some of the states have done of like, who do we think are really probably no longer eligible? They're aging into Medicare. We know they're sort of doing other things with employment. We should start with the redeterminations of those groups first, because it gives other folks more time to figure out what the heck is going on and be ready to actually go through the redetermination process. So there's prioritizing. Consumer education. I just can't say enough about this. Every time I talk about this topic, I'm like, consumer education. It seems obvious, but nothing is obvious when we actually get down to having to have really detailed, complicated notices to people. I know I get them in the mail from the IRS, and I'm like, what is this? You know, so, you know, having not just what's going out from the states, but, you know, working with consumer groups, targeting certain communities, people in the community that folks trust, having those spokespeople to help explain what's happening with the process so people understand what has to be done and why it's important to sort of pay attention to all these long notices you're getting in the mail. And then I'll just say sort of the systems. There are some states that are ahead, and, you know, not all states are going to do this, but, you know, there's auto enrollment processes being put into place in a couple of states so that there is some protection, you know, when there is sort of redeterminations happening, there's an automatic process where they're able to kind of stay on coverage and make sure that they get the full benefit of the process. So a couple of different things I think that we can work on.
Here I am on mute. Interestingly, this is probably the first panel I've had on federal and state topics where dual eligibles haven't come up. And I'm sure that states and our federal agencies are working hard on dual eligibles. It just sounds like other topics have now taken priority. Does that sound right? Or is the dual eligible woven into these themes that we've been talking about today?
Audrey, do you want to take that first?
I mean, I think it's, I would say it's pretty woven in. They haven't necessarily fallen off as a topic of discussion, but I think there's a lot of very timely, very immediate issues that we're looking to that would affect the dual eligibles, and it's including them and looking at them, and really, I think it's just mostly woven in. Our plate is pretty full, so. Trying to juggle everything at once.
Right, yeah. Right. So I have to, I'm going to go back to drugs only because we do have a question about removing safe harbors. And Audrey, I'm going to toss this one to you. This has to do with the Part D rebates from anti-kickback statutes, right? Shielding PBMs. Can you address those specific PBM related safe harbors?
Right. And if you recall, there was also a rebate rule that the Trump administration passed that has been pretty heavily talked about as a pay for in a number of bills by repealing that rule. One of the strange things with that was when the rule was put into effect, the Congressional Budget Office actually scored it as costing something like $177 billion to the Medicare program and to the federal government. So I think there's a desire, obviously, to address PBMs and to address safe harbors. I think one of the big things that we run into is the lack of transparency and needing to be able to follow the money better. I mentioned cost shifting and trying to figure out when you do one thing, how will other entities in the drug pricing marketplace react and in the insurance marketplace. So I think there's a lot of interest in addressing this. I think first and foremost, you're probably going to see more transparency. So since ending some of those under the rebate rule actually came as a huge cost and became not as popular pretty quickly.
Excellent, excellent. So what are we learning from the transparency and coverage that might relate to the kinds of transparency both you and Hemi have been talking about as it relates to drugs? Are we learning anything there? I mean, we've sort of delayed implementation a couple of times on the transparencies and coverage, and this relates to plans as well as hospitals posting prices for consumers to see and for others to see. Are we learning anything there that might be useful, or do you feel that those efforts are really very separate? I mean, clearly one is federal, and then the other at the moment is something that states are noodling over, I'll talk about, but in a very serious way. Hemi, do you want to talk about transparency in that context?
Sure. So, I think the posting of the prices at the health system level, I'll just speak from the state officials we talk to, helpful, but really confusing for consumers. There's a lot that goes into those prices, and how do you discern what's relevant to you? How does that work with your insurance? Like, what does it all mean when you actually go to get a service? So where at least state officials are turning is, let's understand, like just on health system costs, for example, we have people at the state level don't have an understanding, and neither do employers or other folks, what is a hospital's finance look like? So if we decide we want to drive down like what we pay to them, does that mean they'll continue to break even and have profit? Does that mean that they're going to be threatening to close? Like, how do we know how to continue to put pressure on driving down prices, but ensure that the hospitals remain viable? And so that's, in terms of transparency, that's where we're focusing our efforts. We have a new hospital cost tool where states and employers are there gaga over it. They want to actually understand what is it about hospital finances that we need to know so we can make the right policy decisions. I think the same is true on the drug pricing. It's understanding where's the money flowing, that Audrey talked about all those different layers, so states understand, okay, if we have a prescription drug affordability board, or if we decide to do international reference pricing, or we want to think about importation, or whatever the idea is it putting the right pressure in the right place? And one of the things I feel that is challenging is, how does that get transferred down to the consumer? It's like it's slowing the increase in health system costs and prescription drug costs, but then does that immediately transfer to people having lower premiums and paying smaller out-of-pocket costs? Not necessarily, if you don't have other pieces of policy in place.
Excellent. Now, Audrey, what's your take? Are we learning? It sounds like the transparency and coverage then is consumer directed, and the transparency you're talking about in pharmacy is more for the policymakers to really understand where the money's flowing. Does that then sound like the transparency in pharmacy is really a comprehensive one-time study with a follow on a couple valuations, or is it more of an ongoing effort, do you think?
I think that's been proposed as both doing a report to just do a short-term study, but also wanting to look at a long-term. One of the biggest roles that government on any level has is oversight, especially over things as important as healthcare and drug pricing, to ensure that the drugs that come to market are safe and to avoid abusive practices. And so I think transparency is needed on an ongoing level to ensure that we are preventing abuse of certain markets. And to continue understanding drug pricing is an extraordinarily complicated field. And I mentioned a lot of unintended consequences. We have everything from insulin, which is its own issue, to orphan drugs that we don't want to forget and want to ensure are still coming to market. Biologics, and now we have gene therapies coming down the pipeline. It's incredibly complicated, and we want to ensure that we're still being able to fund cures and incentivize cures. We don't want to have drugs come to market that aren't huge improvements. So we are, I think a huge part of transparency is kind of that ongoing study to better inform us on how to formulate better federal policies and practices.
Excellent. So we have our last couple questions actually relate to, and they're one is sort of physician cast, but I'll broaden it to other kinds of clinicians. So is the government thinking of addressing lack of residency spots as or training slots, I'd put it that way, for addressing provider shortages? And that could also be at the state level, right? Because states can also fund slots. Of course, we have specialty societies in there with their slot oversight as well. So what do you think is that in general? Is that particular kinds? Is it mental health? Is it primary care? Is it nurse practitioners? Where do you see efforts around training slots? Where are they likely to come from? And then what else are we doing around primary care? Is it really primary care plus mental health at this point?
I guess I can start on that. Congress is definitely looking at GME and increasing GME to help address our health workforce shortage. It's a little tricky because GME and growing out the GME program will take some time. And one of the big ones that we're looking at is putting GME into more rural and health provider shortage geographic areas, since those are a lot of times where we have a harder time attracting physicians and nurses. I do think there's an interest in being able to diversify, but generally speaking, when we talk GME, we speak pretty broadly. So just residency slots. There has been talk about behavioral health, but when we're talking about increasing GME on a federal level, it's broad to different types of provider types. And I think targeting them to the areas that need them most. So a lot of rural, a lot of underserved areas.
Does that mean tying it into our defined health professional shortage areas through those standard mechanisms, or do you see some new ones coming down?
Yes, so that's kind of the discussion, is how do you target it? So as Hema said, there's a lot of underserved areas looking at equity. There's a little bit of a difference on how you define that. In West Virginia, we have large health provider shortage areas. We are an incredibly rural state, but depending which federal agency you talk to, we may or may not be rural. So when you look at these definitions, it actually makes a really big difference. So are you looking at tying it directly to the health provider shortage area definition, rural versus urban, certain rates of diversity, access to certain types of providers. And then when you talk health provider shortage area, are you measuring that by a full-time provider or a single doctor's office, a specialty doctor that might be there once a week? So it gets really granular on how you target that. And so that's part of the discussion as well.
Excellent. So we are at time, and I really want to take the last minute and thank both of you for a really wonderful discussion, and our audience as well for posting questions to you. It's been a wonderful update and an exciting year ahead. Thank you again, and thank you for coming back to join us.
Thank you.
Thank you so much. Bye, everybody.
Bye-bye.